I will start my slides. It's going to be a joint presentation to myself and Karen Riddell. I'll talk about what's happening first with respect to uh, respiratory issues in our community and how it's impacting Windsor Regional Hospital. Then Karen will focus on the criminal cyber attack restoration efforts and some progress the team has made and what to look forward to over the next couple weeks. So first, you'll see this is the best data that is available, and we've been relying on this actually from the start of the pandemic regarding wastewater levels. And you'll see the wastewater levels for COVID-19 in Windsor, Essex, unfortunately, are moving up to levels we haven't seen since April of even last year, and they're even greater than April of this past year. So a high level of COVID in the wastewater, and as we know, when it's in the wastewater, that means it's in our community. Also what we're starting to see in wastewater is actually the start of influenza. So there's been, as we kind of predicted, we would start seeing an increase in influenza in the month of November. And in fact, now it looks like it's starting to increase rather rapidly in the wastewater where we have influenza A. And provincially, what they're indicating is we're going to start hitting some peak season for influenza over the next couple of weeks. Will be where we're going to be seeing a dramatic increase. RSV is it was high early December, and it's gone down a bit, but it's still present, and that's consistent since our last board meeting. Is we had a number, I think it was in around 9 children at any given time admitted to the hospital with RSV. Now we're down to 3 as of yesterday. We've only had one pediatric test positive for influenza. So we're probably going to start seeing that as well with respect to not only COVID continuing, but RSV and influenza continuing as well. So if you look at what's happening across Canada, the solid line here is this particular year. And you can look at last year as this dotted line is 22, 23. And as we had talked about over the last couple board meetings, is last year was an early year for influenza. It looked like we were going to be about 2-3 weeks behind, and sure enough, we were with respect to the start. Hopefully, the peak is not as high as last year. We shall see. It oddly enough flattened out, which is something that generally you do not see. But again, because of what we're seeing in our wastewater, and also what's being predicted is we're going to start hitting some higher levels of influenza over the next couple of weeks. Again, hopefully it's nowhere near as last year, but we'll have to see how it takes off. But again, it looks like it is definitely a later influenza season than last year, more typical to the average start of influenza for the last 10 years. And again, hopefully the peak is not as high, but we'll have to see. So as a result, what we're announcing as of 12:01 Friday, December 8th, which is tomorrow morning, we're going to be putting in masking rules for visitors when they actually are in a patient's room visiting the patient. Up to this point, we've been highly recommending visitors wear masks. It is now going to be mandatory. So when they're in the patient's room, they're going to have to wear a mask. Our staff have already been doing that since October. But again, we're going to increase it for the visitors. Again, this is a gradual increase in masking. Hopefully we don't have to increase it past this point, but again, while you're visiting, we're going to be requiring visitors to wear masks in a patient's room for the protection of not only themselves, but of course the patients. The other thing I want to highlight before I hand it over to Karen is some news regarding the positive impact of the nurse police team. For the first 29 weeks, they've helped close to 800 individuals in the community. Again, the nurse police team is a program that runs Friday, Saturday, and Sunday nights, where a nurse from Windsor Regional Hospital goes with a police officer from Windsor Police, and they go to where individuals are at in our community. And we have seen a rather substantial reduction in ED visits from those individuals that we have come in contact with. So they've come in contact with, again, close to 800 individuals working those 3 nights from 1 p.m. to 1 a.m. for the 29 weeks. And about 40% approximately reduction in ED visits, meaning individuals who they've actually come in contact with. We trace their ED visits prior to the contact as compared to post, and it's been a dramatic drop off with respect to ED visits. So very, very positive. They'll be able to see individuals in the community. And one of the biggest issues you'll see is the 64 substance related wounds. If we can deal with wounds in the community before they require emergency treatment, that's positive, and they can follow up with these individuals to make sure the wound is clean and doesn't get infected and doesn't require an emergency room visit or something possibly worse. So again, very positive. We are going to be looking at expanding this program to 7 days a week because even though we started the program Friday, Saturday, and Sunday nights, we're seeing there still is a demand, of course, the rest of the week. So stay tuned with respect to further highlights regarding the nurse police team, but really want to thank our staff at Windsor Regional Hospital and the police for quite a partnership. And just recently, a couple of our staff members, Jonathan Foster, as well as Windsor Police, were invited to present at a conference on this very subject in the United States. And they presented, and they were keynote speakers at this conference, actually, to speak about the nurse police team. So kudos to the team in regard to that. So now I will hand it over to Karen Riddell, who will give an update with respect to the restoration efforts post the criminal cyber attack. Karen?
Thanks, David. So just an update on the activities over the past few days. So on a positive note, we have started as of December 2nd, both registering and discharging patients in our electronic system that were admitted and discharged during the downtime period. And this is necessary to be able to build onto those charts. So all of our paper records that we have kept during this downtime will need to be scanned and uploaded into that system. Starting on December 7th, we have started registering our current patients and entering current treatment plans and orders. And we are planning to go live with our electronic patient health record on December the 13th. So over the course of the next few days, we have a very detailed plan where each program will be entering their patients in a systematic way with the plan that we will actually turn the system on Wednesday and be back to electronic charting. So the staff and our professional staff are very excited about this, and we're very much looking forward to getting back online. If you could flip to the next slide, David. So it's important to note, though, this is not a full restoration of all of our electronic systems. We have hundreds of different systems that integrate into the electronic health record. So some of them will not be fully electronic or integrated And I just want to highlight a few of these that are a bit of a larger impact. So from a pharmacy perspective, we utilize medication dispensing units. We use Pyxis units. So these are the actual machines that our medications are dispensed from in the patient units. So they are working, they're just not integrated with the computer system. So right now, when a physician enters an order in our computer system, it would flow to pharmacy. Pharmacy would verify the medication, and then it would flow into the Pyxis unit. And then we would be able to electronically dispense those medications. So those machines will continue to be on override for about 1 more month until we get that fully integrated into the record. From a lab perspective, again, our orders will flow from our electronic record into the lab, and the lab systems are working, but we will not be able to feed those results directly into the health record electronically. So those results will continue to be faxed back to the units, and then they will be scanned into the record. So that's going to be about 1 to 2 more weeks before that's fully integrated. From a diagnostic imaging perspective, our PACS system is not yet up and running. And what PACS is a picture archiving and communication system. So the system electronically stores the images and the reports. And instead of using the old method of manually filing, retrieving, and transporting the film jackets, you might remember the old X-ray films and things that people used to hold up to a lighted system to analyze. So that's what this PAC system does with digital images. And it allows a chronologic view of a patient's radiology history. And it also provides remote access, which is very important. So both our on-site physicians, our on-site radiologists, can access images from anywhere in the building or at either site. And it also makes them available to physicians in our centers that we are referring our patients to. So, physicians in Hamilton can access our images for patients that we are referring to Hamilton or Toronto, London, and vice versa. So that's a really important system that we need back up and running, and we are hopeful that that will be back up in just another week or two. And if you can go to the next slide. So I want to talk a little bit more about diagnostic imaging because it was one of our heavily impacted areas during this code gray because it is so technologically dependent. So how we prioritize diagnostic imaging is based on a system of 4 different urgencies. So there's priority 1, which is emergent and needs to be completed within 24 hours. Priority 2 or urgent is something that should be completed within 48 hours. Priority 3 is semi-urgent, and those should be target to be completed within 10 days. And then priority 4 is non-urgent and to be completed within approximately 90 days. And you can see that ranges from illnesses and diseases that are immediately life-threatening to those where the image is just required for a diagnosis, but it's not something that is life or limb. Next slide, please. So with that, when we're looking at where we're at currently with regards to getting these types of studies done. So for the priority 1 and priority 2, we are running at 100% capacity. And there was no impact on the volumes of the procedures that we were doing during the code gray. So we maintained those. For P3, we have returned, so our semi-urgent, we have returned to 100% capacity for our CT and MRI. The initial impact of the code gray did result in a backlog, and that was due to our PACS downtime. But once our PACS is back up and running mid-December, we're going to be able to ramp up, and we expect that we'll be able to backlog or clear that backlog of our P3s within approximately 10 weeks. For our P4 or non-urgent, we have not been completing any P4 CTs or MRIs, and we don't expect to be able to ramp up for MRI until January of 2024 and CT until February of 2024. So once our PACS is up and running, we are concentrating on our P3 backlog, which are those semi-urgent cases, typically cancer-related cases, or more urgent diseases that need more immediate follow-up. So what we've done during this time period, because of course it's very difficult if you're waiting for imaging for diagnostics, we have informed all physician offices early on in the code gray of the potential impact to wait times to make sure that any patients that clinical condition was changing or there's a change in priority could either be expedited locally or redirected to other hospitals for imaging, or if they're appropriate to wait, as some of the P4s would be. And I do want to share a phone number. So if anyone has any questions about a referral that their physician has sent to us and are concerned about delays or have questions about when they might be booked, please feel free to contact our diagnostic imaging department directly for information at 519-254-1727. And we'd be happy to help you with that. And certainly happy to work with your physician in the community if another resource is required. So, and then I think there's one more slide. So this is just to kind of give you a sense of just a few of the forms. There's a whole other table down the side of this room and at the back of this room with the numbers of pieces of paper that we have had to put back into circulation to support our patient health records and the complexity of what we're doing. And I'm sorry to Mother Earth. I'm pretty sure that we didn't help with the potential for global warming during this code gray, but I just want to give a shout out to all of the staff that have really worked night and day to get us through this. And we're happy to see some sun on the horizon, and hopefully we'll be getting out of this soon and being able to provide better care to our community. So thanks to all of our staff.
Thank you, Karen. So, Madam Chair and the board, that's our report. If